Okay, so um, let's go ahead and get going here. We'll do a quick review of yesterday, and then we'll go from there and make sure you guys are seeing everything pretty good. Okay, good. All right, so let's go. So again, this whole thing of breathing, we have um, four different events. Okay, we have the ability to bring air in and out. We have that ventilation, right? Inspiration and expiration. We have external respiration where we're taking air from the outside and putting it into the bloodstream. We have the transportation of that oxygen, carbon dioxide around the body to the tissues, to the cells, and back to the lungs. And then also we have internal respiration where we're taking these gases from the blood and putting them into the tissue, or from the tissue and putting them into the blood. So we have those four different events, okay? And we talked about that quickly, okay? And so as we go through this and we see this whole thing of inhalation and exhalation, right? We see the creating of a bigger space to allow air to move in, while if we close the space down and we're squeezing, we're just going to squeeze the air out, okay? And so we talked about this external, where actually this from the outside is air that we have breathed in, and oxygen goes into it, and then also the blood brings the carbon dioxide, and the carbon dioxide gets into this space, and then exhalation will occur, and carbon dioxide will be taken out. All right, so we're basically taking stuff from the inside and going to the external, okay, or we're bringing external and bringing it in. So that's external respiration. And then we have this whole cardiovascular thing where we talked about that with the blood and the heart and the vessels and the cardiovascular. That we know what that how that happens. And then we also talked about how Then we also talked about how blood and oxygenated blood, the pressure's high, and so it's going to drive things from the vessel into the tissue, okay? And then that pressure is going to change to where the tissue pressure, the osmotic pressure, the fluid pressure outside of the vessel is greater than inside, and things are going to go get pushed into it. So here we have oxygen and nutrients being pushed into the tissue. Here we have the tissue using, there's that balance, and then here we're going to have wastes and whatever, and carbon dioxide that's built up. That pressure is going to be higher, and that's going to escape into the vessel, and the vessels and the veins are going to carry that back to the heart, to the lungs, to be processed, okay? We talked about this whole cellular respiration, this level of we bring oxygen in, the body uses it to make energy, and the byproduct is water, or is that osmotic pressure, and the carbon dioxide. So we got to get rid of that. Okay, so that's at a cellular level. Okay, and we talked about ventilation. We talked inspiration, bringing air in, expiring, moving air out. We talked about these different pressures, and these are important to know. Okay, you have to get this through your head. All right, so the pressure inside the lung is the same type of pressure, is the same pressure as outside is your atmospheric pressure. All right, if you think about it, there's an open airway all the way inside of you. Right, so those pressures are going to be equal. The trick is that the space around the lungs in the pleural cavity, right, between the parietal pleura and the visceral pleura, that space that has some serous fluid in there, that pressure is lower, which means that lung, when it needs to expand, can do so very easily because the pressure is lower on the outside of the lung than it is on the inside. Okay? So here we are, right? So if we have 760 millimeters of mercury atmospheric pressure, that's going to be the same on the inside of the lung. However, that space between the parietal pleura, the brown line, and the visceral pleura, which is the yellow line, that space is is 4 degrees less, or 4 millimeters of mercury less than what's on the inside. So that lung is able to expand and contract very easily because the pressure is low on the outside. Okay, we have something called atelectasis when that pressure is no longer less and it's equal to, then all of a sudden now that lung is going to collapse. It is unable to expand. It is unable to blow up, and so it pushes down, and therefore we've lost the ability to move air in and out since there's no that pressure difference. And so when you look at an x-ray or something like that, it's going to look like this. We have a nice big lung field. This lung is inflated. The pressure on the outside is lower than on the inside of the lung. And over here we have an issue. Something has interrupted this pressure. Made this pressure equal to, and we see the lung collapsing down. Okay, and a pneumothorax, which some people have heard, is usually due to a trauma, a car accident, getting your ribs cracked or whatever else, and that rib it has if the rib cracks and has a sharp edge and it punctures that parietal pleura, the lining, and now the air is able to get inside there, and then we have a pressure. Now the pressure on the outside is the same as on the inside, and that's going to collapse that lung, and that's what they call a pneumothorax. And so you can see here we have small ones, we have big ones, but the way you deal with that is a chest tube. You have a tube that goes from the inside to the outside. You work on inflating that lung. It's going to push air out of it, and as air gets pushed out, there is a valve here, or this is a one-way ticket, right? So it's not going to allow it to go in and out. It'll be pushed out, and then once it's out, it's out. Eventually, that pressure will get to where it's supposed to be, to -4, and allow that lung to fully expand, and then you're back to breathing normally again. Okay. So why does breathing happen? Okay. So the only acceptable answer, the rule, volume changes lead to pressure changes, which lead the flow of gases to equalize the pressure. Okay, so whatever. So this is a pressure thing. Okay, so volume is going to lead to pressure changes. All right, so you have to get this figured out. Okay, and when we went back to here, if we go back to here and we talk about this, diaphragm dropping, greater volume, diaphragm going superiorly, right? That's going to cut down on the volume. I just had a complete brain fart. Did you see that? Anyway, okay. So, that's what we're talking about here. So when we're talking about the diaphragm dropping, the volume is greater, right? The area is bigger, and that's going to decrease the pressure. And so let's get into this. Okay. So here we go. Boyle's law. Okay. Pressure and volume have an inverse relationship, okay, which means one's high, the other one's low. One's low, the other one's high, okay? So pressure and volume have an inverse relationship. Now look at this diaphragm, this weird shaped parachute-like looking thing that's kind of tucked up underneath here, okay? So at rest, when we're not in the act of inspiration or expiration, the pressure outside, the atmospheric pressure, and the pressure on the inside of those alveoli are the same. Okay? When we inspire, we still have atmospheric pressure out here, but our diaphragm has dropped, which means our volume has gotten bigger, which means the pressure has gone down. And so if the pressure is down and there's pressure high on the outside, that's going to drive air into this area. Does that make sense? So we've increased the volume, which means we've decreased the pressure. So remember, inverse. So if one is high, the other one is low. So here we go. We've taken the volume. All right. So we've taken this area and we've made it bigger. And so if the volume gets bigger, that means the pressure goes down. And so now the pressure is greater on the outside than on the inside, and air is going to go in. Okay? But when the diaphragm contracts and the muscle fiber shortens, so muscle comes down. All right? So when we breathe in, the diaphragm contracts, the volume, the area is bigger. So the pressure goes down and air is going to go into this area, right? High pressure here, low pressure here, air is going this way. Now, when we breathe out, when the diaphragm relaxes, that diaphragm is going to go up. Look how much less volume there is. So if that volume goes down, that means the pressure goes up. And so if the pressure is higher in here than out here, it's going to shoot out of you. All right, so there it is. So you got to remember Boyle's law. If we have a big amount of volume, that means the pressure is low. High volume, low pressure, stuff's going into low pressure. It's going to go from high to low, right? Here we have a low volume, which means we have high pressure. It's going to go from high to low. So it's going to go here to out. All right? So for inspiration, for bringing air into our bodies, we have two main muscle groups. We have the diaphragm and we have the external intercostals. Okay? The thoracic dimensions change to increase the volume of the thorax by half a liter. Okay, so it's going to expand, but not by huge amounts. I mean, half a liter. Okay, so your thoracic cage is going to relax and open up, and that diaphragm is going to drop, and that's going to increase that volume by half a liter. All right, so then what happens is when that does that, when we increase the volume, we're going to decrease the pressure by 1 to 3 millimeters of mercury, and air is going to rush into for normal quiet respiration. All right, so when you just are here breathing and you take it in, that's what ends up happening. Or a deep forced inspiration where you're like trying to suck air in requires the the activation of other muscles as well, not just the diaphragm. Okay, I don't know if I have that in the notes. Okay, so when we talk about expiration, okay, now we're just talking about passively letting air push out of our lungs. When we're just sitting here listening to me, you are passively inspiring and expiring. Okay, inhalation, expiration. A passive process depends on natural lung elasticity, all right? So there is a certain amount of recoil kind of thing. So where you stretch the lung for inspiration, it's going to kind of return back to its shape, and that's going to help push things out, okay? The lungs recoil when inspiration stops so that the alveoli compress, which leads to a volume decrease, causing intrapulmonary pressure to rise. Gas shoots out of you. All right, so regardless, the lungs are going to fill and then they're going to return to normal. And when they return back to their normal shape, with all that air in there, that increases the pressure, which means that pressure on the inside of the lung is higher than atmospheric. And eventually what's going to happen is that gas is going to go out of you. It's going to go from high pressure to low pressure. So from lungs to the outside. All right. So when you force it, it requires the contraction of not only in the abdominals and the diaphragm, not the diaphragm, and other intercostal muscles to take that rib cage and make it smaller and force that, make that volume smaller, which makes the pressure even more, which makes it's going to shoot out of you faster. Okay, so here we are again, right? So we have our lungs, we have our diaphragm. When the diaphragm drops, that makes this area larger. When we have an increased amount of volume, we have a decreased amount of pressure. That means air is going to go from high to low, and it's going to go in. And you're just going to fill those lungs, and those lungs are going to stretch, and they're going to recoil, and they're going to go down. They're going to return back to whatever, to the shape that they were previously, and the diaphragm is going to relax and go up, and it's going to cut down that area, which makes the volume smaller, which means the pressure's higher in here than out here, and the air is going to go out. Okay? So that's a big one. You've got to understand that inverse relationship between volume and pressure. If I have a big area, that means my pressure is going to be low. If I take it and I squeeze that area down, that means the pressure on the inside is going to go high. Okay? So when we listen to people's backs, when you go to the doctor and what they're listening to, they're listening for bronchial sounds, or they're listening for air moving through the trachea and through the bronchi. Okay? And then they're also listening for what they call vesicular sounds, which is air filling the little alveoli, the little grape-like clusters, where that area of gas exchange occurs. All right, and they do that through different points throughout the body, the back, so that they can listen to different parts of your lungs. Right, so you've got wheezing, which is kind of like a whistling sound. I know that if I'd go out and play soccer with you guys for about 30 seconds, I'd be wheezing, and you hear my lungs, and you hear it all, whatever. And then there's also something called rails, which is a rasping type of sound. And I think, the next slide has some examples of those type of things. But we'll see if we can't get that to work. But regardless, different sounds generally mean different things. Okay? And so when we listen to this, let's see if this will come up here. It's blocked. Okay, great. So let's do this. Let's do bronchial lung sounds.
To our Kroger associates, for the long hours and late nights, for the
this is what we're going to kind of, I just want to see if we can get this, so you can kind of get an example of the different sounds. And there's that one down there, that last second medicine thing here. Okay, so we're talking about bronchial, we're talking about traveling here and in the main ducts, like where that mucociliary ladder is, right? The bronchi. Okay, so we're listening to air traveling through here. Okay, so it sounds pretty hollow. It sounds like air is moving in and out of there pretty well. So you're going to listen over the top of the trachea anatomically. Okay, so that is, so now we're going to listen to some vesicular. Okay, so really what we see here is that, if you want to get into this, and we might see this later, but different sounds like rails or wheezing, they kind of are caused by different things. Okay, so let's look here. Okay, physical factor influencing. Pulmonary ventilation can be influenced by 4 physical factors. All right, so pulmonary ventilation, right? So the ability for us to get air in and out of us can be influenced by a bunch of different things, right? And then we know that that's a pressure thing, right? So pulmonary ventilation, it is the volume change leads to pressure change. Okay, so when we talk about what can influence us getting air in and out of us, a respiratory passage disease resistance, right? So you're choking on something, that's a problem. If you have a tumor growing in your windpipe or something like that, or whatever, something like that, if you're going to block the passage for air to get there, you can expect a problem. All right, if you've messed with the conducting portion of things, you're not going to be able to get air in there, then that's a problem. Okay, lung compliance, meaning how pliable is the lung? Can the lung expand? Is it all stiff? Is it messed up? Whatever. The lung needs to expand in order for it to, and then elasticity, right? So is it able to be? Is it stiff? Is it pliable? And will it return back to where it's supposed to be? Okay. And the other portion is now, if we don't have that surfactant around, is that's going to mess with our ability for that to be diffused into the vessel. Okay. So these things can all play a role in this whole ventilation issue. Okay. Respiratory passage resistance, all right? So resistance due to increased friction as air moves through the passage, all right? So smooth muscle bronchoconstriction disorders such as asthma are the bronchi constricting, right? So you have smooth muscle in these walls of these bronchi, okay? If you get some spasms of these muscles, it can cut down on the airway, making it difficult to get air in and out of the lungs, and that's asthma. Okay, so it can be something like that, right? It can be something like the smooth muscle is constricting that and cutting down on the airway. That's what asthma is. And then also, mucus, infectious material, tumors, anything that would get in there, right? So with a smoker, right? With a smoker's cough and they smoke for a long time, they can get that mucus buildup. And if they're not coughing it up or they're taking cough suppressants, mucus can get in there. That can mess with the airway and block the air passages. We don't want that, right? Air is kind of important, okay? And so when we look here at asthma, here's a normal bronchi and here's an inflamed bronchus, right? Look at the difference in the amount of area for air to get in and out of the lung. It's a big difference, okay? And people that have lots of asthma, they get inflammation of these walls. So when you take your inhaler, or you take a treatment, you're taking a steroid, right, or an anti-inflammatory mist, and you're breathing it in, and that's being exposed to the vessel walls. That's going to cut down on the inflammation, which is going to make that area bigger, more like this, and now all of a sudden, I can breathe again. Okay? So, we'll do one more slide here. Or two more slides, these two here. Okay, so lung compliance. Okay, so we talked about this. So we just went over that one. Respiratory passage resistance, right? So it can be inflammation with asthma or bronchoconstriction with asthma. Or it can be mucus, it can be tumors, it can be whatever is kind of in the way and is not allowing a smooth, friction-free airway. Okay, and then we talked about lung compliance. How well can the lungs expand? Are they stiff? Are they what? We want that to be loose. We want that to be. So when that pressure changes, those lungs will easily expand. Now, if that's not the case, and that's called lung compliance, right? So it's affected by the elasticity of the lungs and the thoracic cage, which can be diminished by too much. Okay, so fibrosis of the lung tissue, right? So you can get, so now look, fibrosis. We've seen that before, right? We've talked about the healing by regeneration, and we talked about healing by fibrosis, right? Healing by regeneration is by the similar tissue cells that it's replication of normal tissue cells, and you don't have a scar. But here, when we have regeneration by scar tissue, by fibrosis, that's going to leave a scar. Now, if you have a bunch of scarring in the lungs, which is supposed to be able to expand and recoil a lot, that's going to mess with things, right? So healing by fibrosis, okay? Ossification in our muscle paralysis impairs the flexibility of the thoracic cage, right? So if we've lost the ability for our muscles to help the rib cage expand, then we're not going to be able to, the lung won't be able to expand as well as it could because the rib cage is not getting bigger. The diaphragm will drop, but if the rib cage won't expand a little bit, that's going to mess with your compliance, your ability for your lung to fully inflate. Now, look at lung fibrosis here. That is pretty scarred up. When you're talking about all those little alveoli and those areas of simple squamous thin tissue for air exchange to go through, this doesn't look like simple squamous thin tissue. It's a lot of fibrosis, which makes that lung hard to expand, and it's going to mess with also the recoil of it as well. So we will continue on early next week, and we'll go over some more of this. The big thing that you have to grasp is the pressure changes. You have to make sure that you understand Boyle's law, right? You have to make sure that you get that you want it. If you increase the volume, you decrease the pressure. If you decrease the volume, you increase the pressure, okay? Make sure you understand that. If you don't, you need to get with me and you need to ask questions, all right? We'll probably have one more day of lecture next week on Monday, and then we will I'll have a Zoom on Tuesday for review and a sheet, and whatever, and quiz on Wednesday. All right, you guys have a great weekend. Although it seems like every day is a weekend. You guys have a good weekend, and let me know if you have any questions. Have a good day.